Okay, good morning and good evening, all our good friend. I am Dr. P.Y. Cho, and today I am Dr. Junior to moderate this webinar. Today we are so happy to have Professor Percy Rossell-Perry, and Professor Percy Rossell-Perry has a very impressive background in the plastic surgery and academia. In his education, Professor Percy Rossell-Perry completed his human medicine studies at St. Marcus University in Lima in 1993, and he completed plastic surgery training at various institutes in 1993. Professor Percy's further training included in Emory University in Atlanta, UCLA, the Craniofacial surgery program, and his academic achievement. He obtained a master's degree and a PhD degree in human medicine from St. Marcos University and complete a diploma course in clinical research at Harvard University. And further, he is also should he completely authored multiple books on clinical and pilot treatment and chronic cutaneous bleeding and various researchable techniques. His publication include more than 50 scientific articles in index journals and over 700 citations so far. And in his editorial roles, he served on the editorial board of the Journal of Craniofacial Surgery and was a board member for the plastic reconstructive surgery. Association leadership, Professor Perry is the president of the Latin American Craniofacial Association from 2018 to 2020. And his current role is the president of the Smile Train South American Medical Advisory Council and a member of the Smile Train Global Research and Innovation Advisory Council. Today we have 4 panelists who join us. The first one is Professor Kitoku. The second one is Professor Anda. They both come from Japan. And we just finished and complete the Tokyo Cleft in the past 3 days in Tokyo University. And the third one is our good friend, Professor Rossell from Asa Medical Center from Seoul. And one of our panelists today is Dr. Chang Yan, and Dr. Yan is one Rhinoplasty master in Memorial Hospital. Can't wait to learn from Professor Percy Rossell-Perry. His topic today is the unilateral primary rhinoplasty. So let's welcome Professor. Yes. Professor, please.
Okay. Thank you very much for your invitation to this important webinar. I'd like to express my gratitude to Dr. Lo and Dr. Panjun for assistance and invitation, and also all of the panelists here. And may I proceed with the presentation, please? Okay.
Yes, please.
Okay, let me do it. Just a second. Here. Can you see?
Yes, we can
Yes.
see.
Perfect. Excellent. Okay. This is my personal experience during almost 30 years attending patients with cleft lip and palate and regarding unilateral primary cleft rhinoplasty. No conflicts of interest to declare. These are the lecture goals. Focused presentation in primary nose repair of unilateral complete forms based on the surgical nasoalveolar molding concept and presenting also long-term studies. This is our unilateral cleft lip and nose treatment philosophy, comprehensive restoration of form and function, no presurgical orthopedics, and operate less, preserving tissues, single stage, and fewer revisions. This is our protocol. 3 to 6 months, primary rhinoplasty using the pool-modified method for kiloplasty and the BYC rhinoplasty. Around 5 years, the alveolar cleft closer and minor lip nose corrections. During mixed dentition period, the Bohlenberg graft, and during the adulthood, definitive cleft septorhinoplasty and probably lip refinements, and no use of presurgical orthopedics. This is our evolution. Initially, probably during 10 to 15 years, we were using a conservative treatment for the primary nose repair based on McCann type, doing nasal tip dissection and reposition using transcutaneous stitches. Then we moved to Potter BY with some success, and later using the BYC, which is the actually surgical technique used for unilateral cleft lip and nose. This is a good example that we were moving from the conservative treatment to a more aggressive one. You can see here, this is a complete unilateral cleft lip and palate, and we were doing a dissection of the nasal tip, and then using transcutaneous stitches, and the outcome is looking very good after treatment. But during the evolution, there is a relapse, as you can see in the photo in the right side. So 20 to 74% of primary cleft rhinoplasties based in this concept require revision. So it is too high. In that way, we decide to move to another technique, trying to improve the quality of our outcomes. These are frequently asked questions in primary cleft rhinoplasty. First, the decision to do or not to do. Then, the use of presurgical orthopedics. Which surgical technique is better? Role of primary septoplasty, post-operative nasal stents. Why the nasal deformity relapse? Is the primary cleft rhinoplasty safe? And finally, nasal surgery affects the nasal growth? We will try to answer all these questions during this presentation. This is a background. Some evidence suggests that performing nasal repair at the same time as primary cleft lip surgery has an adverse influence on the subsequent growth of the nose. This is a study, however, the study methodologically has some limitations because of a small group and following during 7 years. Therefore, the conclusions are limited. However, this is a systematic review study published last year regarding the impact of the primary nasal repair during cleft lip repair regarding growth restriction. The conclusion is this: the majority of the studies reviewed support that primary rhinoplasty during unilateral cleft lip repair results in good outcomes with limited or no effect on nasal growth. Therefore, this is a study published 2 years ago. We can say that performing primary cleft rhinoplasty is becoming more common among cleft surgeons. Considering comparable cost and complication rates, a rhinoplasty should be considered during the surgical treatment planning of patients with cleft nasal deformities. Looking at our surgical methods, this is the primary cleft rhinoplasty I like to use, which is a modification of the pull kiloplasty and based on Tennyson Randall concept, using a big triangle for medial rotation located between the two subunits, the supralabium and the infralabium, which are two subunits of the philtrum. This is important because sometimes when the rotation, when the cleft repair is not well performed, the alar base is located in lower position. This is common when we are using linear techniques or small triangle techniques, and they used to be the alar base in lower position. So this method helped me to position the alar base in correct location. This is resume of the caloplasty. The nasal mucosa is repaired using the lateral mucosal flap, medial and lateral, and the muscular dissection, which is a key point in nasal repair. The muscular lip repair is a key point in nasal repair. This is important. I like to point it. Look, the nasal fascicle of the levator levi superioris alekinesi, which is here illustrated in this diagram, is important to support the alar base. There are three muscles here. In fact, there are two, but the orbicularis has two segments, the marginal and peripheral, but we are using the nasal fascicle of the levator levi superioris alekinesi. Look at this video. I will show you an important anatomical structure that should be identified to be used to support the nasal base. Let me close the video and I will show you here. Look, this is the lip repair. We are performing the dissection of the muscle at the lateral segment. These are the muscle here. We are separating the skin and an structure is coming to appear here. Look at the top there. This structure is not described in the literature. This is a fibrous tendon, and the auricularis and the elevator nasal fascicle is included there. And this is important to be used, here, to be used to support the base of the nose. This is attached to the membranous septum. We are not performing primary septoplasty, in fact, in most of the patients, but this muscular component in one block with the orbicularis oris is attached to the membranous septum to obtain the outcomes that I will show you today. This is the base of the nose, and we are correcting it using the flaps from the ala, lateral, and the base of the columella here in B, medially, and supported by the muscle I mentioned. Look at this. This is interesting case. It's severe. Look at the position of the maxillary segments. This is almost in very, very bad position, and we can correct completely. The base of the nose can be completely corrected using this muscular repair. That is very important to be pointed, because we used to think that the position of the ala cannot be corrected until the alveolar bone graft time. And this is not true under our experience. Look at the maxillary arch also. This is the spherical nasoalveolar molding concept, because we believe that the surgery can be correct, the nose, can be correct also the maxillary arch without the use of any plate, because the muscular repair is the best orthopedic, it's more physiological. And can you see in the left side, this is a maxillary arch correction performing plates using NEM device. And in the right, we can see the position of the segments using only primary lip repair and nose by muscular action. I think we use fewer interventions to obtain similar outcomes. And this is more efficacious because we believe there is not a burden of care of patients. Can you see here presurgical orthopedics? And can you see here the action of the labial muscles based on the surgical NEM concept? These are true studies. One 2011 and later in 2024, and both of them concluded there was no statistical significant difference in the long-term three-dimensional anthropometric measurements and dental model analysis between the NEM group and non-NEM group, because the muscle can act in the same way as the plate is doing. This is the unilateral cleft lip nose deformity standard of care. We are performing primary rhinoplasty, but also can use presurgical orthopedics and postoperative nasal conformers. Regarding unilateral forms, we believe that only the primary rhinoplasty and postoperative nasal conformers can be used with excellent outcomes. We decided not to use, we were using presurgical orthopedic during some time, but after our experience using this method, we believe that we can achieve good outcomes without presurgical intervention. This is the surgical technique. I named that the BYC. This is a B composite flap, including the skin of the vestibule and alar cartilage. It's a B composite flap, which is advanced medially, and then we have lateral C-plasty. There is an advancement here and lateral C-plasty. That we are creating is an elongation of the nasal vestibule, which is, this is exactly what the nasal molding is doing, is expanding the vestibule, but the problem is that the presurgical orthopedist needs the surgery, cannot be done alone. So in that way, the surgery is producing the same effect, but this is having a long-term outcome, and we don't need presurgical treatment. That is the reason. And also there is an interesting conclusion about this expansion of the vestibule, that we are not looking the cartilage, because the framework, we can correct the alar cartilage because we can move it, but we are not paying attention to the lining, because in our understanding, the most common reason of relapse of the nasal deformity is the lining retraction. So conservative treatments, as I showed you before, these treatments are, the problem is that the lining is not expanded, and then when the scar contractor appears, there is a kind of relapse. That is why we decide to elongate the lining with the outcomes I will show you now. This is a video I will show you about the method. This is the deformity. You can see it's a severe form. It's a unilateral complete cleft lip and palate. I will advance. Look at there. The position of the medial segment. The outer cartilage here, the nasal septum deviated. Can you see here the lateral segment there? We can say that this is a severe deformity. Okay, this is important. I will show you here. Okay, this is the vestibule. Look, the lower incision is performed around the intercartilage incision, and the other one is marginal. Marginal and intercartilage. Then lateral incision here. This is a kind of VY initially there. We are proceeding now for nasal tip dissection. There, I will show you there. That's the nasal tip dissection. There. There is. Then we have our composite flap. That is the composite flap elevated, the galar cartilage and the knees and the vestibule of the skin is included. And then laterally, we are performing here the C-plasty, which is important because this lateral C-plasty has two purposes. First of all, the expansion of the vestibule, and secondary, the prevention of the lateral web, which is more common using presurgical orthopedics, because the presurgical orthopedics is expanding more medially and not laterally. Then there is a kind of limited lining in the lateral position, and the lateral C-plasty is preventing the lateral web. The section of the C-plasty here, that is the composite flap, and then the lateral C-plasty there in that position. Okay? We are starting closing. We use transcutaneous stitches. This is, first of all, positioned, the dome is positioned through transcutaneous incision, stitch, sorry, coming out, the same point coming back, as you can see here, coming back in same position, there, and hold, and then appear in front of our initial point here, there. Pulling the dome to the right position, and you can see how is this expanding actually. We are continue, same here, same procedure with the lateral point of the B composite flap. Here, same stitch, coming back in front of the initial point, and we are positioning the B composite flap. We are positioning the B composite flap there. And the alar cartilage is positioned. Same, we are complete with additional stitches. Same at the intercartilage incision here. Same there. Expanded that we did that the BY, and now we are performing lateral transcutaneous stitch to perform the lateral C-plasty there. Same stitches completed there. medial interdermal transcutaneous stitch also is performed there. There. And complete our C-plasty laterally there. There. Can you see here the expansion? The vestibule is expanded and the other cartilage is positioned. Can you see the final outcome in this video? Post-operative view. And we may continue. Sorry. Here. This is an vestibular elongation done by orthopedic NIM. Can you see that the nasal stent is molding a segment of the vestibule? It's not expanding all. And this is creating the lateral web. Can you see this is the lateral web? This is an unilateral cleft lip and palate, and the nose was molded using presurgical orthopedic. And the lateral web is common here because the molding is performed more medially. And our technique in the right side, can you see that the vestibule is completely expanded through this BY advancement and the lateral C-plasty. This method in the left needs orthopedic procedure and additional surgery. The surgical nasoalveolar molding concept use only one surgical method. I think we are correcting the burden of care of the cleft lip nose treatment, and we are using fewer procedures to obtain good outcome, as I will show you. Regarding septoplasty, actually, this is a trend that we are performing more septoplasty than we used it in the past. But honestly, we are observing correction of the soft tissues in nose repair in cleft lip patients without the use of the septoplasty. And of course, we are performing that, but only for severe forms that we are showing in this slide. These are our rates of nose complications. Can you see this is a study published by us in 3 groups of patients, the technique A using Mekong method, the technique B, the Potter VY, and the technique C, the VYC. This is an observational study, and we can see clearly that the problem here is in 3 groups are the granulomas because of the kind of transcutaneous stitches. Initially, we were using Vicryl, and actually we moved to the PDS, which is producing less reaction and less granuloma, but rates are similar. Scar contractor are more common in the group of the Potters and are lower in the BYC because of the lateral C-plasty we added to the method, to the Potter's method, and the synechial also important in Potters, and also we have around 4% of synechia in technique C. This was not observed using Mekong, and this is very important to be pointed because we are moving to a more aggressive method. There are also complications related to these extended incisions inside the nose, and some recommendations are provided in these presentations to prevent this complication. I like to present my long-term follow-up and long-term outcomes using this method. This is a study with 37 non-symptomatic primary complete unilateral cleft lip patients. We measured the nose and lip measures, as here you can see here. And in the nose, we use the columellar angle, also nostril dome height, columellar length, nasal base width, alar base position, and also lip measurements. These are our outcomes. We can see that at 1 year and 5 years of follow-up, we cannot see, because this is the p-value, the statistical significant difference between non-cleft and non-cleft side and cleft side regarding nostril dome height, nasal base width, alar base position, and columellar length here, and also at the 5 years old. Here, this is an outcome. 1 year outcome. Can you see this is a severe form of unilateral cleft lip and palate? And we look at the deviated columella and the position of the alar base, and this is the outcome after 1 year. You can see the base of the ala is completely corrected and symmetrical because of the utility of the muscle repair, which is supporting the alar base. Look at the nostrils, they are symmetrical, and also look at the columella, deviated initially, and they completely corrected without the need of a septoplasty. That because we are correcting the soft tissues deformity and not the framework. Of course, the patient needs probably later septoplasty because of the airway problems, but we can obtain nasal aesthetic outcome and a good outcome without a septoplasty. And because the septoplasty is not, the primary septoplasty is not correcting the airway problems because it's not completed. It's also only a portion of the septum corrected. And in that way, I believe that this is not necessary in all cases and only can be used for severe forms. Another case, this is not a good outcome, even when this is a severe form, and this is performing without the help of presurgical orthopedic as the case presented before. But look at the position of the bases, look at the severity of the unilateral cleft lip and palate, and look at the bases are in good position. There is still a small difference between the nostrils, but can be easily corrected during nose revision time to obtain a final good outcome. Another case, look at more symmetrical nostrils, the position of the columella and the base of the ala is in right position. Also, lip outcome, can you see, is good. Another case, can you see the same, similar deformity, similar degree of severity, and you can see the nostrils, the symmetry of the nostrils, the position of the columella, and the other bases. We cannot wait until the bone graft time to correct the base of the ala. This can be done using a proper primary surgical technique. And also it is important to perform an adequate lip repair because the straight lines or conservative limited incision technique used to locate the base of the ala in lower position. Another case, this is a 5 years follow-up. Can you see the deformity here complete? And you can see the bases and the symmetry of the nostrils and the follow-up after 5 years here. 1 year, 5 years. Look at the nose, there is no restriction of the growth at this time, and the symmetry of the nose is remained. Another case, you can see another complete case, 1 year, look at the symmetry of the nostrils and the position of the columella and the bases of the nose. There is no relapse, there is no restriction of the growth during this follow-up. look at the maxillary arch, is corrected by muscular action. I believe that we don't need any plate to correct the position of the segments, and can be done by muscular action. Another case, more severe here, you can see the bases and you can see the symmetry, not completely symmetry of the nostrils, but can be corrected easily during nose repair, secondary nose repair time. Look at the maxillary arch. There is an alignment of the segments done by muscular action only. Another case here, look at the position of the bases, look at the columella, initially severely deviated, and there is a small difference between the nostril, but can be easily corrected using a conservative secondary method for nose repair. Look at the maxillary arch, it's aligned. This is the surgical nasoalveolar molding method done by one shot, done by one time, surgical time, performed by muscular repair and nose repair. Conclusion of this study is the primary rhinoplasty alone is a good approach to improve nose appearance and maxillary arch in patients with unilateral cleft lip, nose, and palate deformity measured during preschool age. Attention, please, this is very, very important. Regarding the method, the BYC cleft rhinoplasty needs training. This is not an easy method. This is an aggressive method in some way, and they should be trained. The surgeon should be well trained to perform this procedure. The complication can be a disaster because it can be a collapse of the nose if it is not well performed. So the use of postoperative nasal stents is mandatory and should be guaranteed. We have had a close relation to the parents to guarantee that the conformist should be used and will be used during the postoperative time, at least during 6 months, to avoid any scar contracture and synechia. If this condition is not guaranteed, we cannot proceed with this method. In fact, we are using another conservative method, which is the rotational composite flap method, but this is used by us for incomplete forms. And this is another alternative and can be used if the use of postoperative nasal stents is not guaranteed. Preoperatively should be guaranteed. We have to talk to the parents, explaining the procedure and explaining the potential complications. And if it is not guaranteed, we cannot use. And finally, I do not recommend the combined use of BYC-NM or any other or presurgical orthopedic, because this is our experience, that the nasal stent is producing some affection of the expanded tissues. Sometimes this is producing injuries. And also, any expansion is affecting the nasal blood, the vascularity of the tissues, because the expansion is producing some the expansion this is creating that the blood flow is reduced in that area. So if we are elevating flaps, I believe that maybe we may have some problems because about the viability of the flaps and also the scars that the method may produce may affect the final outcome. So in that way, I do not recommend the combined use of BYC and NEM because there can be a disaster. This is another study with longer follow-up time, period of follow-up. This is another retrospective cohort of 32 non-syndromic primary complete unilateral cleft lip nose. We use the pool Craniofacial and the BYC method. at 3 months old without presurgical orthopedic and measured it at the age of 1 year and later during mixed dentition period, which is around 9 and 11 years old. We measured nostril height, nostril width, and nasal width, illustrated here. We use a scale to evaluate our outcomes, grade 1, grade 2, and 3. Grade 1, no difference in measurements between cleft and non-cleft sides. Therefore, no secondary revision is necessary. Grade 2, the difference in measurement of the cleft and non-cleft side was less than 3 millimeters. Therefore, minor secondary revision is required. And finally, when the difference between the measurements of the cleft and non-cleft side in postoperative time was 3 millimeters or greater, this therefore needs major secondary revision. This is the outcome. Follow-up mean 8.2 years, and grade 1 outcomes was 40% of patients. 40% of patients obtained total nostril symmetry, as I showed you in some cases before. Grade 2, we observed grade 2. Sorry, this is, excuse me, I think, right, I can see here. Yeah. Here we have, this is a problem with the slide because the grade 2 is around 56%, and grade 3, which is the more severe outcome, is 3%. There is a problem in this slide. I think I typed it in badly. But we have 40% in grade 1, grade 2, 56%, and grade 3, 3%. These are the outcomes here. You can see the percentage of, you can see here in nostril height, this is A, 1 year of follow-up, and B, 7 years follow-up, at least, more than 7 years. And you can see here nostril height, scale grade 1 to 3, 40% here. Here you can see grade 2, 50%, okay? Nostril width, grade 1, 40%, and grade 2, 59%. And alar base width, grade 1, 40%, and grade 2, 56%, right? And grade 3 only 9% here, and here there is another problem in the slide here because this is 3, not 30, because this is not complete. Okay. And you can see clearly scale 1, 40% in 3 measurements. And in A and also in B time, during mixed dentition period time, we observed 30% here, 34 to 37, and which should be pointed, and then 34% in alar base width in this table. Here, the cases, then this is the initial deformity, and you can see here during the follow-up, mixed dentition period, front, bore eye view, and close view of the knees of the nose. Can you see the symmetry, the alar bases, and columella? Another case here, initial deformity, mixed dentition period, nose deformity, small difference in this case. Another case, initial deformity, mixed dentition period, front view, one eye, here, closer view. In upper photos, you can see the nostrils here, columella and nasal base, and the repair. Another case during follow-up, mixed dentition period, same alar base, nostril needs minor correction here in fact, minor correction here to obtain total symmetry. You can see in these cases, probably it's not a good view, but you can see in these cases that there is no a lateral web here, which is prevented by the use of the lateral C-plasty. Look at another case here. Look at the position of the bases, columella corrected. You can see here the position of the septum is not corrected, but this is not affecting the aesthetic outcome of the nose, and of course need later correction. Look at the position of the nose and symmetry of the nostrils. And this is interesting because we have discussion during Milan meeting with Dr. Raymond say about the utility of the septoplasty, primary septoplasty. And this is interesting to illustrate. This is a long-term outcome, and the outcome is maintained in the nose after long term. But look at the initially, there is the deviation of the septum can be observed during short-term follow-up. Look, there is a deviation in the 1 year follow-up, and this is more prominent during long-term follow-up. Look, the deviation is observed here. And in this particular patient, is more prominent than others. And we believe probably, and also, well, I'm not sure, but the correction of the caudal septum is not improving this deformity. But I cannot say this because this is not studied, but probably yes. But look at the position, the correction of the caudal septum is not correcting the posterior section of the septum. In that way, it's probably that the caudal septum reposition that is recommended by some authors is probably not correcting the deviation of the nose. And maybe can be proven later by secondary septal rhinoplasty. But that we can say now is that the symmetry of the nose can be achieved, the nasal tip deformity can be corrected and can be warranted after long term. Same case, another complete. Can you see the bases, the columella, and you can see, and this is in not the right position, but you can see the nostrils here. Conclusion, the proposed primary cleft rhinoplasty is an alternative approach to improve nasal appearance in patients with complete unilateral cleft lip and palate with low rates of major nasal revisions measured during mixed dentition period. Finally, there is another study regarding postoperative nasal conformance. This is a common question between cleft surgeons. This is a retrospective observational cross-sectional study, 95 Peruvian infants from Lima, Peru, with non-syndromic complete unilateral cleft lip and palate or with primary cleft lip node repair using pole clearoplasty and BYC between 2012 and 2016, followed through 2021. We did not perform any type of surgical management of the patients. Methods customized postoperative nasal conformers were used for at least 6 months in 52 patients. This is group A. Conformers were not used in 43 patients, group B, for different reasons, economic or detected poor compliance by the parents. All patients meet the study criteria, having anthropometric measurements obtained under general anesthesia immediately before the alveolar bed close. Nostril nose measurements using caliper, nostril height, nostril width, nasal base width, and columella length. The scale, 3 degrees, as I mentioned before, since no secondary revision necessary, 2 major secondary revision required. establishing differences between the cleft and no-cleft side. These are the nasal conformers we're using for at least 6 months, 8 hours each day to prevent scar contracture of the vestibular incisions in the group A. The conformers were customized using during manufacturing and applied 1 week after surgery to prevent any associated complications during the early process of wound healing. Each device was manufactured from a mold created from an impression taken from the patient nose and fashioned from acrylic material to create stands. This is a kind of developed country nasal conformer. And I believe that the silicone conformers are more appropriate because of the nature of the material and is more fair to be used in the patient. But these are more expensive and these are difficult to be created because they are fabricated and can be used for each patient. And in that way, we decide to move from to use the acrylic nasal conformers, and these devices have a perforated extension that is inserted into the nose to keep the airway clear, as I can illustrate here in the photos, and the conformers are designed bilaterally and supported using a wire framework. They are attached to the inside of the nose with the aid of a tape that is adhered, as you can see here, to the framework. The appliance is adjusted according to the patient progress by the addition of the acrylic to the stent. These are our outcomes. Daily use of nasal stents in group A, mean 11 hours. In group B, mean 10 hours. Total duration of use in group A, 7 months, and group B, 7 months. Non-statistical significant difference between these variables. Grade 1, total nostril symmetry observed in 40%. In group B, total nostril symmetry in 37, non-statistical differences. In grade 2, similar, 52% of the patients. In group B, 58. And grade 3, 3% and 4%. And non-statistical differences between both. But groups, you can see here the p-value and the percentage of the nasal outcome degree in each group, as I mentioned it before. And regarding complications, we can see here in this table that the granuloma is observed around 50%. This is related to the use of the transcutaneous stitches, as I showed during the surgical technique explanation. And the scar contractor has been observed in group A using conformers in 7.69%, and in group B in 27.9%. So this is statistical significant different. And in group B without nasal conformers, the scar contractor are more common to be observed, and also synechia is similar. The use of conformers in group A were observed, provided that 3%, 3.84% of synechia in group A and 20% in group B. So scar contractor and synechia are more common in the group without the use of nasal conformers. And pinched nose also a non-statistical difference between two groups, around 6 to 7%, and infection very rare also. So what This is group A with nasal conformer, and this is group B without nasal conformer. Nasal aesthetic cannot be improved by the use of nasal conformer. That the aesthetic outcome of the nose is provided by surgery and cannot be improved by the use of nasal conformer. This is our conclusion. The results obtained in this study show that the placement of postoperative nasal conformers does not improve nasal symmetry in patients with unilateral Cleft. However, may reduce rate of scar contracture and synechiae. Additional studies are required to evaluate the functional outcomes and conclusion about the effectiveness of these devices of nasal symmetry can be done. What can we say actually? Better nasal outcomes can be achieved using by presurgical orthopedics. These are common conceptions. I believe may be debunked. I think good outcomes can be obtained without the use of presurgical orthopedics in unilateral forms. Name operated lace and fiber revisions than surgical alone. I'm not sure because you can see here fewer revisions can be needed and fewer interventions can be done without using orthopedics. Postoperative nasal conformers improve nasal aesthetic. Our study is not concluded that. I believe that the conformers are not improving the aesthetic, are preventing retractions and synechias. Nose deformity will relapse over time and secondary cleft rhinoplasty is always required. I believe the outcomes are maintained during the follow-up and maxillary arch alignment can be obtained using only orthopedic plates. I showed you that the maxillary arch can be aligned using only by muscular action, and adequate position of the nasal base can be only obtained after alveolar bone graft. You can see the position of the bases by muscular repair only. In summary, use a technique for primary cleft lymph node repair are effective in obtaining labial and nasal symmetry measured in the long term until the mixed dentition period. Low rates of major nasal revisions have been observed during the follow-up time, and additional studies are required. These are my published textbooks. You can see these contents in these books. And finally, in advance, you can see here that this year is coming the Atlas of Primary Cleft Rhinoplasty, published by Springer, and all contents are included in these textbooks. Thank you for your attention.
Wow, Professor Rossell, this has truly been an amazing webinar with very exciting and very advanced topics. So at this time, I'd like to invite our panelists for some discussion. So first one, I'd like to invite Professor Datsuk Oh from Asan Medical Center in Korea. Professor Oh.
Yeah. Wonderful. Congratulations on your wonderful result. And actually, the nasal symmetry is wonderful that I'm so impressed by your result. And I have a question because you're compare with the other technique with the primary rhinoplasty regarding the incision over the skin. Your incision, you use the VYG plasty, that it means that your incision to expose the lower lateral cartilage, the inner part of the nose. So, but I really want to know that sometimes the skin, nasal skin envelope is expanded before rhinoplasty and cleft repair. So how can you address that expanded flap just the inner part of the incision? So it is very wonderful. That I really want to know your technique and the result.
Okay. Yeah. Sorry. Is there a question? Can you please? Is there a question?
So it means that is there any case that there is a medial part skin hooding after the VIG plasty?
Oh, okay, right. Okay, thank you. This is very important, right?
Yeah.
Let me tell you, initially, when we are looking, many years ago, when we are looking to go to the primary repair, we were performing secondary corrections, okay? And most of the authors initially correct the nose in a secondary time. And all the primary techniques are coming from the secondary techniques. And this is an example of that the BYC is coming from secondary repairs because we were using the BYC in secondary cases initially. And I observed good outcomes. I say this may works primarily. But there is a difference. When we are performing the BYC in a secondary time in adult patients, okay, we have to include an graft here to prevent the pinched nose here, because it should be prevented, because if you move the alar cartilage immediately, there is a lack of structure here, and there can be a pinched nose, a retraction in this portion. As you can see in our long-term outcomes, this is not happening during primary time. It is not clear for me. I'm not using any graft here in patients in all the cases I presented, and probably this is related to the extension that the cartilage is moving, and this is not too much to be positioned, and the needed of cartilage graft is not necessary. That is, I observed during all this time until the mixed dentition period. Of course, if it is happening, can be corrected using a cartilage graft during secondary time. And the outcome can be preserved. So, but I didn't observe during all this time that the pinch and knot of retraction, but of course, I accept that it will happen. It will happen. And we may be prepared to reinforce the area with a small portion of cartilage graft. Sure. Good question.
Thank you. Thank you.
Thank you. Thank you.
Thank you, Professor O. Our next panelist is Professor Kyotoku from Kansai Medical University in Japan. And I see that Professor Kyotoku also raised some questions in the chat room. So, Professor Kyotoku?
Yes, thank you, Professor. I really understand your lecture very well, and very good result. I am impressed. My first question is that what is biggest hindrance for against the relapse of the nose?
Okay.
You say that you haven't used any PNAM even in very early years of the baby. You do not necessary to PNAM, pre-surgical molding at all.
Right. Right. Okay. This is okay. We have. I like too much this discussion because just the last meeting in Milan, there is a divided session regarding them, and every meeting is again, and we have 30 years using name, and we are still debating. So something is not working as expected, really. And it is clear. Look, we are producing an expansion using a device, okay? This is a pre-surgical treatment. But this expansion is not a long-term outcome. It is clear. That is the reason why you need the surgery after the molding. The question is, the outcome is related to the pre-surgical molding or the surgery. That is not clear because there is not an adequate level of evidence published to support that. Probably a clinical trial using same surgeon, two groups, providing one group using the pre-surgical molding and surgery and the other using surgery only, with performed by the same surgeon. It is not easy to be developed, this study, I agree. But I think I did systematic review, published it about this topic, and there's no evidence. In fact, probably there is not, because after 30 years, we should have enough evidence, but there's not. I have one question. How much do you need to correct the nose if the nose is corrected after the molding? It's impossible to know that, to have that answer. Because if you are molding with using a device, you have the nose corrected. And when I'm performing the surgery, I don't know how much should be corrected. So there are too many questions. I believe that the relapse after using conservative treatment is related to the lining, because the lining used to contract after surgery because of the healing process. And this is producing the contractor. But this is producing the relapse. So I observed that because I've been doing almost 15 years conservative method using dissection and stitches, but it wasn't working well. So this method works better. The outcomes are better at this time, follow it during long time. And I will continue with this study until the adulthood to obtain the last answer. But I believe that probably I accept that this is aggressive, and I accept this is potential complications can be observed. I accept that. The nasal conformers are mandatory, of course. So, but at these times, I believe that the good outcomes can be achieved by one shot, by one surgery, using this method. That is, I can say that naturally.
Okay.
Thank you for the question. Yeah.
One more. Your BYZ procedure at your first chiroplasty, you do not any over corrected, just symmetrical.
Thank you. This is another position. This is the overcorrection. And I did it because I learned that method during my times in Chang during the workshops. I've been attended each 2 years during since
how much amount?
Since 2004, I believe, since the beginning. I love it always, and I appreciate too much that I learned from the professors in Chang. And I've been doing, but the problem is this. Of course, it works, but the problem is that some noses remains overcorrect. And it's more difficult to correct an overcorrection than an undercorrection. Undercorrection is easily, but the overcorrection probably needs some graft, or because there is no tissue there. So honestly, I believe it's safer for me to preserve tissues. That is why in my philosophy, treaty management for cleft nose, I believe that we have to preserve the tissues, and the resection of skin is another method. I don't believe this is good because we have to preserve tissues to have a better scenario during secondary times. That is, I believe.
Thank you.
Thank you. Thank you for your questions, doctor. Thank you.
Thank you, Professor Kyotoku. Next, I'd like to invite Professor Honda from Iwate Medical University in Japan. So, Professor Honda.
Okay, Professor Rossell, thank you very much for your lecture. I have one question for you. The question is similar to Professor O from Korea. In my patient, I sometimes feel that the medial side of the nostril drooping, but in your patient photo, you don't have such a drooping of the nostril medial side. So what if do you make the nasal cartilage fixation or moving to the posterior or upward fixation or not? Thank you.
There was a loss of connection during your question, but I understand that you are asking about if I'm attaching the lower and upper lateral cartilage and medial attachment. That is the question?
Yes. And do you make this lower lateral cartilage to be more posterior movement or upward movement?
Right. Thank you. Thank you. That is correct. Because the video was, you know, it's a short video. In fact, it is not providing more details. Okay. But any structure can be detailed, positioned, and also this is a great question. And the upper portion of the alar cartilage is not in right position regarding the upper lateral, and this should be corrected. I showed you during the video that one stitch is positioned at the alar dome in the lower portion here, and then we have to use another here to reposition the upper portion of the alar cartilage. Okay, same stitch and should be positioned. When you see inside the nose of the vestibule, clearly you can see that the alar cartilage is not in right position. It should be changed, and the stitch can be done. This is another stitch used. This is not detailed, and in that way, your question is helping me to illustrate more. And of course, we have that I'm doing is this because the anatomy of each patient is different, and the formula of the surgical technique is a promedio. It's a median of the patients. But when you're performing the surgery, and in that way, the experience is necessary also in anyone. We are learning every day. You have clearly, you can see where you should put the stitch because you are repositioned in the upper portion. It's a 3D. It's a 3D. In the upper portion, in lower, medially, and laterally, and you are correcting. That I recommend always is I used to operate the patient in front of the head, here, okay? And when I'm performing the rhinoplasty, I recommend to turn and see the big wide, the warm eye view of the nose. And see clear the position of the nostrils, and then inside the vestibule. And looking for the correct stitch in the correct position. And there is not a formula, really. The anatomy can be different in patients, and the anatomy of the nose. So the position of stitches should be placed regarding the anatomy of the patient. And of course, about your question, and another stitch should be placed here. Sometimes, in more severe forms, this is not positioned in the vertical line. It's more medially moving. It's a kind of overcorrection in some way, right? But more medially in some severe forms. Yeah.
Okay, thank you very much. And
Thank
how
you.
wide do you dissect the over the cartilage? Do you dissect for the normal side also?
Sure, but this is small. But I am attaching one alardome to the other, so we have to create that area, that space, to locate the alardome in the cleft side, attach it to the non-cleft side. So I dissect, but not to extend it. I believe even in severe forms, I show you, today I present the more severe forms. I will show you minor, everybody's happy. I'm happy, everybody's happy. But I believe that we have to present the severe forms. How can be correct? And I don't believe that we don't need any extended decisions. I've seen some included dissection of the infraorbital pedicle and nose dissection to the nasal dorsum. I don't believe it is not necessary. Really, we have to create a space enough to make room to the alar calcium. And this is, but I perform it. I perform it around the dome of the non-cleft side. Sure.
Okay, thank you
Sure,
very much.
necessary. And also the upper lateral. cartilage.
Okay,
Sure. Thank you.
thank you very much.
Thank you, Doctor.
Thank you, Professor Panda. The following panelist is Professor Yan from our Chang Memorial Hospital. So, Professor Yan. Oh, Professor, you're on mute.
Okay, sorry about that. So can you hear me?
Sure.
So
Hi.
I want to thank you, Dr. Rossell. Yeah, hi, nice to meet you. I want to thank you for your great lecture, and I'm also impressed very much about your great outcome. So actually, I'm not a really cleft surgeon, and I do much more traditional nasal reconstructions and also the adults rhinoplasty more. So but I think that in our nasal reconstruction, traditional nasal reconstruction, we follow the principle that developed by Dr. Burgett and Dr. Manick, and we divide the nose into the different subunits, and we reconstruct it by the defect involving the subunit. But I think sometimes I also get some patients asking for some secondary revision of the cleft nose, but I think it's really totally different story and I feel that it's really challenging. Yeah, even challenging than the something like forehead flap, the free flap, something like that. So I think the cleft patient is really the structure is different and I think it's really challenging. Yeah. So, but luckily we had some experts in our craniofacial team, like our two moderators and also Dr. Low. I think he's also online. So I think they also take very good care of our cleft patients. So actually, I don't have questions, but I'm really enjoying your lecture, and I learned a lot from your lecture. Thank you.
Thank you. Thank you very much. Thank you.
Thank you, Professor Yan. And last but not least, I'd like to invite Professor Low for some comments.
Dr. Percy, I enjoy your talk. Very nice result. And I also like to congratulate you that you know for a long time that you have gradually improved the technique and have put very nice result, and you have a long-term follow-up. I think for the audience, we need to mention that primary rhinoplasty really is a good technique. I mean, everybody have your method, because previously, even now, there are still people feel that primary rhinoplasty can result in nasal growth problem or even the scarring issue, something like this. So I think the message tonight is that primary rhinoplasty is a good technique, and shown by you that you can have a long-lasting result. Really nice. Now, I would also like to clarify that because name has been argued for many years, and to be honest, name is only performed in some maybe minority of center or surgery because of the availability or burden, and you need a good orthodontist to work together. So you do not use NAM, I think it's fine, because you have a very nice rhinoplasty technique that can correct the nose deformity. But the argument is that, to me, alveolar molding is more important than nasal molding. I also have a good rhinoplasty technique to correct the nose problem. But alveolar separation, and then you do the lid repair, the muscle is, you have to dissect really is not easy. I would like to listen to your comment. How do you manage the alveolar separation before the surgery? Do you do any kind of orthopedic management other than NAM?
Right. Initially, we were using the method, the loop repair, nose, and we were following the patients. And during palate time, we observed the maxillary arch. And we didn't use any surgical treatment. And during palate time, we observed alignment of the segment. And we were surprised. Oh, this is corrected only by the muscular repair done during lip repair. So, and when we perform the alveolar bone graft, we have another time to evaluate. And without the use of any plate, the alignment of the segments is observed. So, in that way, we consider there is nothing else to do. I showed in this presentation the arch, maxillary arch, and they are aligned. There is no collapse. Probably is related to the muscular repair. There are different ways to do. The most common mistake in muscular repair is the incomplete muscular repair. And this is performed only in the lower, medial lower position. And then the nose is lowered because the muscle is not repaired in the base. This is the most common. And probably there are different ways, and there is a deficiency in the muscular reconstruction. Therefore, there is a problem in the alignment of the segments. Probably that is one reason. The other can be the palate repair. This is not studied. This is what I estimate actually. I observed there is no reason to use a plate to align the maxillary arch. I presented severe cases. You can see the distance. These are not small. So, and the maxillary arch are correct. So I believe actually we don't need. I think the support of the orthopedics, the orthodontics is very valuable, but should be used properly. More is not always more. The efficiency is when less is more. And the burden of care is important in cleft patients. So I believe at this time, bilateral is different, bilateral is different. So regarding unilateral, I believe can be corrected by muscular action. That is, I believe, and measure it also during this time. There is a question in this session regarding the long term, that the adulthood time. I continue. I will do it. I believe in some years. My final answer regarding this treatment, and I will know if it is work or not at that time regarding maxillary arch, regarding the aesthetic outcomes. That is, I believe, doctor. I think experience is very important.
Yeah, truly experience.
Sure. I think there are many variables, right? The surgical thing, the patient, but I believe probably the most important is the experience, the surgeon's experience. Because I compare my cases during my initial years and now. And for the young surgeons, you need time. Wait. Don't run. You need time. You can do that, and you can do better, because all this information, we didn't have all this information. I have 30 years involved in this field, 30 years. Look at my hair.
Okay, Dr. Percy, I do have another question that I would like to hear your comment. That I observed from your video that you do the nose first and then the lip repair. Is that correct?
During the surgery, right? That I'm doing is this. I did the surgical markings, but I start the surgery performing a small incisions, very superficial, to don't lose the markings in the lip. And then I have all the nose open because the cleft is open. And this is the best time for the surgical approach.
Mhm.
If you perform that after lip repair, this is reduced.
Yeah.
And
Yeah.
as I am using incisions inside the vestibule, so it's not easy sometimes because you have to go
Yeah,
there.
yeah.
Yeah, so I did it before lip repair, right?
Yeah, because in my mind that if you repair there's a microphone problem. When I repair the lip, the muscle will bring the low-lateral cartilage together, and at that time the area will change its shape. But you already repaired the area already, so the sequence just looking at your surgery, just I have to spend some time to figure it out. That I always prepare the lip first and then go to the nose.
Right. Different approaches. I believe the outcome should be mandatory, right? Different ways, but the outcome should be. You can do that with pre-surgical, post-surgical treatments, or I think in that way the experience is important to support the outcome. But the outcome should be previous. I am doing more aggressive. I believe that, and this is another thing, that the complications can be severe. Can be severe. I've seen cases from other surgeons looking the presentations and they are going to perform. This is not a good idea. The surgeon should retrain it. And the patient came and the nails closed, completely closed. This is very important. Potential complication, but more aggressive treatment, more complications and more severe complications. And this is very important. I have another technique used for incomplete, which is the rotational composite flap. And this is more conservative treatment. And I'm using that for incomplete forms with the deformity. There is a less deformity. And I believe that that can be used as alternative. Not the same outcomes, but it's improving the nose because there is a rotation of the nose, the color cartilage, and in a complete rotation, the same dissection, the skin and the other cartilage is rotated and the donor side is closed primarily. So it's an alternative if you are not comfortable performing this aggressive method. But I'm been doing because of the outcome. That is the answer.
Thank you very much. Good job.
Thank you, Dr. Lu, for your invitation. Thank you very much. Thank you.
Thank you, Professor Lo. Now, due to the time restraint, so what we're going to do is we're going to collect all the questions that we have from the chat room, and then we'll send the questions to you, Professor Rossell, and then you could email us back, and then we'll post your answers on our Facebook group for everyone to see. Would that be okay?
Sure.
Okay, thank you very much. So we're very happy today to have Professor Rossell here with us and giving us such a great talk with such a great panel discussion. So thank you, Professor Rossell, and thank you to all our panelists, Professor O, Professor Kyotoku, Professor Honda, Professor Yen, and of course, Professor Lo. Now, before we go ahead to our group photo, I'd like to advertise our next ICC webinar, which will take place on August 11th, and it will be by Professor Dong Ngoc Guam from Vietnam. And then the topic of that webinar will be Phasing Out Traditional Model Surgery, Application of Dental Technology in Complex Orthodontic Surgery. So we hope to see you on August 11th. And once again, before we go to our group photo, there is just one more thing that I'd like to share with everyone. So here is actually our Changdong Forum of 2024, and this will take place in Changdong Memorial Hospital from October 28th to the October 30th. And then it's a 3-day event, and then we'll talk about the clefts, orthodontic surgery, and then we'll also have video demonstrations of these surgeries. So please join us, and then please register if you haven't already, and we hope to see you in Taiwan. Okay, so lastly, let's go to our group photo. So everyone, please open up your cameras for us, and then we'll take a photo. Oh, great. We have a good crowd today. So on 3, then we'll take a screenshot. So 1, 2, 3, cheese. Okay,
Cheese.
our next group of photos. 1, 2, 3, cheese.
Cheese.
Okay. Thank you, everyone. And thank you once again for joining us today. We'll see you all on August 11th. And please register for Chang Forum if you haven't already. Thank you again, Professor Russell.
Thank you. Thank you very much.
Everyone.
Thank you very much, Professor Russell.
Thank you. Thank you.
Thank
Thank
you.
you.
Thank you,
everybody. Thanks for
Professor
your invitation.
Professor
Great time.
O, Professor
Thank you.
Yutoku,
Bye
Professor
bye.
Handa, Professor Chen Yi. Thank you, EK.